Hello and welcome. In dentistry, pain control isn't just a nice to have, it's everything. It's the absolute foundation of trust and a successful procedure. Being able to deliver profound anesthesia can take what could be a really stressful situation and make it completely manageable, not just for the patient, but for you, the clinician, too. So let's dive into the techniques that make it all happen. Have you ever stopped to think about it? How can one tiny, well-placed injection make a whole section of someone's jaw go completely numb? It almost feels like a magic trick, doesn't it? Well, it's not magic. It's a masterful blend of science and art, specifically a deep understanding of neuroanatomy. It all comes down to knowing exactly where the nerves are and how to safely get the anesthetic solution right to them. We're going to pull back the curtain and break down exactly how it's done. So here's our game plan. We'll start with the core concepts. The foundational strategies behind every single injection. From there, we'll get specific and focus on mastering the upper jaw, the maxilla, before we tackle the tougher challenge of the mandible. After that, we'll cover some essential soft tissue blocks, and we'll wrap it all up by talking about why precision is just everything in modern dentistry. Okay, before we jump into the really specific injections, we've got to get the basic strategies down. Think of these as the three main tools in the dentist's pain management toolbox. You've got infiltration, the field block, and the nerve block. Each one has a totally different target and a different job to do. First up is local infiltration. Now, this is your most direct, pinpoint approach. Let's say you just need to numb a very small patch of tissue around a single tooth. With infiltration, you're putting the anesthetic solution right there at the site, targeting those teeny little nerve endings right at the surface. It's perfect for small, contained procedures. Now, if you take a step up from that, you get the field block. Instead of numbing just the immediate tissue, you're depositing the anesthetic near some of the larger nerve branches that feed that area. This creates a field of numbness around where you're working. It's awesome for procedures that might involve one or two teeth. The supraperiosteal injection, a classic field block. And that brings us to the heavy hitter, the nerve block. With a nerve block, the whole goal is to numb an entire region. You do this by depositing your solution way back, close to a main nerve trunk, often pretty far from where you're actually working. This is how you can get an entire quadrant of the mouth profoundly numb, which is absolutely essential for bigger procedures. So let's just boil it down. The key difference is all about scale. Infiltration is super local, hitting just those tiny nerve endings. A field block is regional, going for larger branches near the site. And a nerve block, that's widespread, targeting the main nerve trunk to numb a huge area. Getting this difference is absolutely key to picking the right tool for the right job. All right, let's move on to our first specific location, the maxilla, the upper jaw. The bone here is way more porous than in the mandible, and that's a huge deal because it means anesthetic can diffuse through it much more easily. This unique anatomy really dictates the kind of techniques we're going to use. We're going to start all the way at the back with the posterior superior alveolar nerve block, or the PSAN. This block is incredible for getting the maxillary molars numb, so your second and third molars and most of your first molar. But, and this is a really, really important but, it often misses the mesiobuccal root of that first molar. That's a classic exception you have to remember. So to nail the PSAN block, you have to know your landmarks cold. Your needle is going to go in at the height of the mucobuccal fold, that's that little groove where your cheek meets your gums, right above the second molar. But you're not just aiming straight in, you're aiming for a very specific spot in 3D space. The needle has to go upward, inward toward the middle, and backward. That specific angle is what lets you place the anesthetic right where that nerve slips into the maxilla. Okay, now look at this number, 28%. What's that all about? Well, it's actually fascinating. It represents how often the middle superior alveolar nerve, or MSA, is even present in people. This is the nerve that's supposed to handle the premolars and that tricky mesiobuccal root of the first molar. But this means that in about 72% of people, it's just not there. In those cases, the anterior nerve takes over. It's a wild anatomical variation that explains why sometimes one block just doesn't do the trick. All right, let's move to the front of the mouth. Here we've got the anterior superior alveolar nerve block, which you'll often hear called the infraorbital block. This is a really powerful injection. It numbs a huge area from the canines all the way to the midline, plus all the surrounding bone and soft tissue. Your entry point is way up high in that groove where the lip meets the gums, usually right over the canine. So far, everything we've talked about covers the teeth and the cheek side tissues. But what about the roof of the mouth? The palate is
famously sensitive, and getting it numb requires two very precise injections, the greater palatine for the back part and the nasopalatine for the front. The nasopalatine block especially can be a real doozy for patients if you're not careful. So, a really clever and gentle way to do it is with a multi-stepped approach. You don't go straight for the palate. Instead, you start by numbing the tissue on the lip side. Then you can pass the needle through that already numb tissue between the teeth to approach the palate. By the time you do the final injection into the palatal tissue, the patient barely feels a thing. It's a fantastic technique for patient comfort. Okay, let's head downstairs to the mandible. Anesthetizing the lower jaw is a completely different world. The bone here is so much denser, so much less porous than the maxilla. Because of that, infiltration techniques just aren't going to cut it for the teeth. Down here, the nerve block is king. And the absolute workhorse of mandibular anesthesia is the inferior alveolar nerve block, or the IANB. When you get this right, you get profound anesthesia for almost an entire quadrant. We're talking all the teeth to the midline, the floor of the mouth, the chin, the lower lip, and even the tongue on that side. It is incredibly effective, but boy, is it technically demanding. Getting the INB right is all about landmarks, landmarks, landmarks. You use your thumb to feel for the coronoid notch. That's the deepest part of that curve on the front of the jawbone. That tells your height. Then you spot the pterygomandibular raphe, that little curtain of tissue in the back, which tells you how far in or out to be. Your syringe barrel usually rests over the premolars on the opposite side, aimed right at that very specific target zone. Now this is the single most critical piece of feedback for the INB. You must feel the tip of your needle gently make contact with bone. That's your confirmation. It tells you you're at the right depth and in the right spot. If you advance the needle and you don't hit bone, you've gone too far back. You need to pull back and redirect, otherwise you risk injecting into the parotid gland, and you don't want that. Okay, so even when you deliver a perfect primary block, sometimes you need to do some fine-tuning. That's where all our supplemental blocks come into play. This could mean advanced mandibular blocks for those really tough cases, or specific injections just for soft tissue, or even super targeted techniques for that one stubborn tooth that just refuses to get numb. So what happens when a standard INB just isn't working? Well, you have options. The Gaugates technique is a true nerve block that aims much higher up at the neck of the condyle. It has a super high success rate, but it requires the patient to open their mouth really wide. On the flip side, you have the Vazirani Akinosi, which is a closed mouth technique. This is an absolute lifesaver for patients who have trismus and can't open wide. And let's not forget the soft tissues. A great INB will numb the teeth and the lip, but it won't get the gums on the cheek side of the molars. For that, you need a separate buccal nerve block. And similarly, a mental nerve block is perfect if you're only working on the soft tissues of the chin and lower lip and don't need to numb the teeth or tongue. These little supplemental blocks are what ensure total comfort for the patient. So as we start to wrap this all up, there's one central theme that connects every single one of these techniques, and that's precision. A deep knowledge of anatomy, a careful and deliberate technique, and a real focus on patient comfort, these aren't just suggestions. They're the absolute standard of care in modern dentistry. You know, this quote from the source material really just says it all, doesn't it? Mastering these techniques goes so far beyond just getting a procedure done. It creates this amazing positive feedback loop. When you reduce a patient's fear, you reduce their stress. And that, in turn, reduces your stress as the clinician. It's a win-win for everyone in the room. This whole journey through dental anesthesia really shows you just how far we've come. But it also makes you wonder, right? What's next? With all the incredible advancements in imaging, in guided technologies, in pharmacology, how much closer can we actually get to a truly 100% painless dental experience? It's a really exciting future to think about. Thanks so much for joining me today for this explainer.